Today we will be discussing about emphysema. As an introduction, it is a chronic lung disorder that is characterized by abnormal, irreversible, that is permanent dilatation of the air spaces distal to the terminal bronchioles. That is, the distal parts of the terminal bronchioles includes the respiratory bronchioles, alveolar ducts, and the alveoli. Moving on to etiology, the first major cause is inflammatory mediators that are released by leukocytes. That is due to some infections, the leukocytes release some inflammatory mediators. The second one is protease antiprotease imbalance. That is, the proteases degrades the proteins, thus causing the lysis of the alveolar walls and all. So genetically, we have the balance between protease and antiprotease. But due to some factors, there may be an imbalance between the protease and antiprotease, which can lead to the permanent dilatation of the alveolar wall. That is example in case of alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is a antiprotease. The third factor is oxidative stress, mainly due to the tobacco smoke, which damages the alveoli and it causes the damage to the epithelium, which produces oxidants. Then the fourth one is airway infections. When any infections come, the leukocytes come to that point and they release the inflammatory mediators, which also causes permanent dilatation of the alveolar wall. So we have discussed about the etiological factors. Now moving on to pathogenesis. If any of these etiological factors come into action, this causes the inflammation or damage to the respiratory epithelium. As a result, neutrophils and macrophages infiltrate this area and they release cytokines, elastase and protease. This elastase results in the breakdown of elastin present in the alveolar wall, which results in the loss of elastic recoil. As a result, there is irreversible enlargement of the air spaces, which causes the collapse of respiratory bronchioles. As a result, there is decreased surface area, which causes hypoxemia. As a result, finally it leads to emphysema. Talking about the clinical manifestations, the first thing that begins to appear is dyspnea, which begins insidiously and steadily progresses. And the second one is cough and expectoration. Weight loss is also common. On clinical examination, the chest appears to be in the shape of a barrel shape, that is barrel-shaped chest. The complications includes congestive heart failure. Talking about the types of emphysema, these are mainly classified according to its anatomical distribution within the lungs. So there is mainly 4 types based on their anatomical location. That is, first one is centriacinar, second one is panacinar, third one is distal acinar, and the fourth one is irregular. We will be mainly focusing on 3 points on about the classification. That is, where inside the acinus is this lesion occurring, and where inside which lobes of the lungs is affected as a whole, and what are the associations, that is, what are the main causes of such lesions. Talking about centriacinar, which is the first type, this mainly involves the central part or the proximal part of the acini. That is, we have told about the respiratory bronchioles, right? That is the parts that are distal to the terminal bronchioles. So the proximal part of the respiratory bronchioles are only affected, while the distal parts of the respiratory bronchioles, that is the alveolar duct and the alveoli, are not affected. Only the respiratory bronchioles are affected. So that's about where inside the acinus it affects. Then within the lungs, it mostly only affects the upper lobes, and it is only seen in association with heavy smokers. That is centriacinar is seen in case of heavy smokers. Talking about panacinar, which is a second type. The panacinar, from the term itself, the pan means the whole part. So as a result, we can conclude it as the whole part of the acinus. That is, the respiratory bronchioles, the alveolar ducts, and the alveoli as a whole is affected in this kind of emphysema. Talking about the part of lung, the lower lobes are mostly affected, and it is seen in association with alpha-1 antitrypsin deficiency. That is, in people who have alpha-1 antitrypsin deficiency, the most common type of emphysema that is seen is panacinar emphysema. Talking about the third type, that is the distal acinar emphysema. From the term itself, it implies that only the distal parts of the acini are affected. That is, the respiratory bronchioles are not affected. Mostly the alveolar ducts and the alveoli are affected. And the lobe which is affected, it is not in terms of lobes. It is seen in association with pleura. That is, the regions that are close to the pleura are affected. It is seen in association with areas of fibrosis or scarring. The fourth main type is irregular. That is, we can say where the exact part is part of the SNA is affected. It is irregularly affected. That is, SNA is irregularly involved. It is the most common form of emphysema, and it occurs near the scar around the old healed inflammatory processes like tuberculous scars. You can pause and look for the picture that I'm showing now. Now we will be discussing about the morphology of the emphysema. So talking about the growth, you have to memorize 3 important points. We know that emphysema is the irreversible dilatation of the air spaces. So as a result, because of this irreversible dilatation, the lungs becomes voluminous. That is, the lungs appears voluminous. Then the second point you have to remember is the upper two-thirds of the lungs are affected, and you can also see bullae are also seen. These are the 3 main points. That is, voluminous lungs, bullae formation, and upper two-thirds of the lungs is affected. Talking about the microscopy, large alveoli are seen because of the destruction of the alveolar walls, and bullae may also be seen. We can also see some inflammatory cells and the inflammatory changes that occurs at the air spaces.